eczema. I always tell Mpilo to use the emollient whenever she feels itchy instead of scratching. After a bath or swimming, I dry the skin gently by patting it and then put the emollient on as soon as possible. I use a thick layer and smooth it on gently from the top of the body towards the bottom.
SBR instantly hydrates the skin and replaces skin-identical lipids. SBR effectively reduces symptoms within 7 days. With daily use, SBR reduces the need for topical steroids for up to 12 months. To avoid contamination, it is always better to use a nozzle or to squeeze from a tube. If this is not available, use a utensil and replace the lid as quickly as possible. Aqueous cream may be used instead of soap, but it should not be used as a moisturizer because it may irritate the skin.
When my child's eczema is bad, I use a corticosteroid cream or ointment directly on the bad patches. They reduce the inflammation and quickly make her skin smoother and less red and swollen. I use a steroid for the fast effect and quick itch relief from day one.
During a flare, the skin is being damaged by the eczema and the steroid ointment will prevent that damage. Once a flare is under control, a lower strength ointment should be used and then slowly reduced until it can be stopped and just the emollient continued. Emollients must be continued at the same time as steroid ointments are used. Use the steroid ointment directly on the skin and cover it with a layer of the emollient.
Mpilo's eczema used to come back very frequently. Then my doctor gave me a different ointment to use once she's better. I put it twice a week where the bad places are to stop the eczema from coming back and to prevent us from having to use more steroids. When Mpilo's skin is really bad, I use wet wraps. I put the ointment on, then cover it with a wet layer of bandages or clothes and then her normal pajamas afterwards. When Mpilo uses wet wraps, she sleeps well and the skin gets better quickly. The next morning her skin is smoother and less dry and itchy, and I find we even use less of steroids.
The Allergy Foundation sells a special range of clothing called Kiddie Calmwear to make wet wrapping easier and more effective. It's important to identify and avoid triggers that can worsen your child's symptoms. Common triggers include harsh soaps, certain fabrics, fabric softeners, hot showers, and overheating. Work closely with your healthcare provider to develop a treatment plan that's right for your child. Managing your itchiness means you need a plan that includes medicines, avoiding certain things, and using emollients regularly.
Mpilo's action plan tells me how often to use emollients and what steroids and other ointments I should use. I learned to use the emollient regularly to reduce her symptoms, give her healthy skin, and help her live her best life despite eczema.
So I can feel better, sleep better, and enjoy my life with healthy skin.
Help us to help you. Go to the Allergy Foundation website at www.allergyfoundation.co.za and sign up the Allergy Foundation as one of your beneficiaries on your Woolworths My Schools, My Village, My Planet card.
Hello and welcome, dear friends, at our atopic dermatitis support group meeting, our live support group meeting. It's such an honor to have Prof. Carol Clela with us again. You will remember that she was on one of our previous meetings, and she is just so absolutely wonderful, giving her time freely to us. Just a reminder, I'm Sarita Kannenberg. I'm a dermatologist in the northern suburbs, and Prof. Clela is the head of the pediatric dermatology department at Red Cross Hospital. Forgive my piece of paper here, but we have such a full program today that I've been told to keep the time, and therefore I just need to remember what we had on the agenda. Now, today we're going to be discussing today we'll be discussing a very touchy subject and a very, very important subject, and that is corticophobia. But before we get to that, Prof. Leila, welcome. And if you don't mind, we've been talking about atopic dermatitis, eczema, but maybe you can just give us a very, very short recap on what this condition is and what we're going to be discussing today.
Sure. Thank you so much, Suretha. There is a lot of fear about the use of corticosteroids at this day and age. And I'm very grateful to Sanofi, AFSA, to provide a platform like this where we can educate each other. But to answer your question about eczema, I think it's common knowledge. A lot of people do understand eczema to be, I'm referring to the atopic type because there's many types of eczema, but we're talking about the atopic one. It's that common skin condition that is genetically determined, that is marked with patches that tend to be itchy, particularly in certain areas of the body, and it usually is in front of the elbows, behind the knees, and it can also affect any, from top to bottom, meaning scalp right up to the toe. But the common sites are those that I've referred to now, especially in children. At the moment, we do not have the cause, but there's multiple factors that have been implicated, genes being just one of them, but environment, abnormal skin barrier effect, as well as immunological dysfunction. So there's many causes towards its manifestation on the outside.
Yes. So tell me, why do we as dermatologists put so much emphasis on corticosteroids? Why do we use it? And when I say corticosteroids, of course, I mean cortisone creams. There are many, and we'll be discussing that as well. Many on the market, but this is something that we as dermatologists use daily since about the 1950s, I think, when it was initially discovered, isn't it?
Yeah, exactly.
So why do we use it for eczema?
Thank you for referring to that study, that groundbreaking study that was published in 1952 in particular. But the reality is that since that study, dermatology has never been the same. Certainly towards, I can probably focus on eczema. Dermatology in general has never been the same, but certainly towards treatment of eczema. But to date, Suretha, and I'm very happy to be directed differently, but to date, topical corticosteroids remain the mainstay treatment for atopic eczema. There are other options. Problem, though, is that they do not equate in terms of their efficacy with topical corticosteroids.
Absolutely. Especially in certain atopic dermatitis conditions, I've seen that hand eczema, for example, there is absolutely nothing that works like a topical steroid, isn't it? Yes. So why are people so scared of topical steroids? And we use, everyone knows agoraphobia, or people with an agoraphobia is, if I remember correctly, these are people who are scared to go outside. And then we have, so why are people so scared of it?
Yeah, okay. I'm happy to answer your question just now. I thought maybe I could just define what that is, what we're talking about, corticophobia. We are talking about that irrational fear of the use of topical corticosteroids towards treating any skin disease, and eczema is included in there. So, and I have to quickly say, as a clinician, this is a fear that our general fear that I share with, the parents and providers. I'm talking about care caregivers of parents of patients with eczema. I share that fear with them. So in other words, I'm not undermining that it's possible for topical corticosteroid to cause side effects, adverse side effects with time. Yeah. But I'm as yet again to underline the how much I value this platform, because I just think that what is lacking, and if we were to pinpoint where the problem is, we would say there is lack of patient education on how to use corticosteroids appropriately so that they do not lead to the side effects that people fear so much. It doesn't help. Yeah, it doesn't help that there is, so many sources of this that perpetuates this fear. There's a study that was conducted. I cannot remember the exact year it was published, but it showed that the corticophobia problem has ranged from 21% to about 83% at this moment, at this day and age. And I mean, the reason that it's risen so much is because there are a myriad of sources that lead to this. Social media doesn't help it. So patients share this information that is incomplete. I actually am trying to avoid using the word misinformation, but you know what I mean. But they share this incomplete information within, for example, let's say people are waiting in the waiting room in the doctor's room. Family members, neighbors who are well-meaning, I must say, but unfortunately just do not help the situation. And it doesn't help, yet again, that there are certain healthcare professionals, fellow healthcare professionals who also perpetuates the problem. So just because, I mean, of course, those healthcare professionals need the platform such as this, the one we are embarking on today, which is just using platforms such as to spread the correct word to educate everybody, including themselves. But all I'm saying, though, is that the sources are mirrored. And just because there's so many sources, it's very hard to cap the problem. Instead, it's going unabated. And I believe that this is an attempt to try and put a stop to it.
Yes. And the vast majority of people actually now, probably in the younger age group, so if I'm referring to maybe 20s to about 50s, so we're still in there, Carol, so we're still in the younger age group. But that group tends to get the most of their information off social media, isn't it? Yeah. And off the internet. So, and that's why it's so important for these type of meetings, I believe. And we actually have, just for interest sake, we actually have another sponsor today. So Adcock Ingram is also sponsoring us today, and they will be showing some of their emollients a little bit later, because that's one of their big fields. But so yes, we need to thank our sponsors for that as well, for this opportunity. And I once again need to thank you for giving your time for free. So thank you very much for that. And for all the people that are involved with that. Yes, so I mean, what I have found actually as from my side, also as a clinician, is that I often give a prescription, and then when the patient comes back for follow-up, then I find that they haven't necessarily used it properly, because they often get scared. Actually, they get that fear gets put into them often, unfortunately, because of their contact with the pharmacist. So this is also a group of people that I hope will be watching this today. And that we can just make sure that we're all on the same page, because our patients look at us to be able to advise them on this. But also, Carol, where can patients find someone who will be able to help them with their atopic dermatitis?
Sorry, I missed the question. Where can they find them?
Yes. So who do you think would be the best person to advise them and to treat their atopic dermatitis, especially if we're looking at the more severe cases?
Sure. So firstly, Sarita, let me just start by saying one of the problems that also contributes to this big problem is that patients, when they see the word steroid, they just lump what they know about steroid with everything that says steroid. For example, there's anabolic steroids that are used particularly in the bodybuilding industry. And there's systemic steroids, which will come in the form of intravenous or oral, and then topical corticosteroids. And they somehow patients think that these are at the same strengths and therefore they lead to the same side effects. I just feel like it's our duty to help tease these out for the parents, for the patients, and help them to understand, particularly because what is relevant for atopic eczema is usually the topical corticosteroids. These are different. They are different to the anabolic steroids. They're different to the systemic steroids, and therefore the side effects shouldn't be viewed in the similar manner as well. But then reality, though, is that it takes a skill for example, for a healthcare professional to know what steroids to use, topical in particular, which one to use, at what site, how long, that which is required for the appropriate use of steroids. And I do think that obviously the best person to do so is a dermatologist. I'm aware that there is not enough of us and there's a lot of patients who suffer from the disease. I really therefore hope that at least other healthcare professionals, general practitioners, pharmacists, they embark on a let's say they open themselves up to being taught as to how to use these steroids rationally, not irrationally, rationally, so that they truly do make a difference in the patients that they are treating. So to answer your question, where do patients find the best place to be treated for eczema? It's obviously going to be in a dermatologist's room, but I'm very aware that it's not practical, 100% practical. But where you can, best entrust such a task to a dermatologist.
Yeah. No, I agree 100% with you. And the public can actually find dermatologists who are interested in atopic dermatitis or who are interested in eczema. The names of those practitioners they'll be able to find on the Allergy Foundation of South Africa's website, but also on the Dermatology Society of South Africa's website. So have a look at those names, and then you'll be able to find. What I have neglected to say, and I'm very, very sorry about that, is please post all your questions. I hope you brought your questions. We will attempt to look at the most of the questions that we can write, during the live. But if we don't get to those questions, then we'll be able to answer those for you afterwards as well. So please don't be scared. Just post your questions. So Carol, tell me, how effective and safe would you say corticosteroids are?
I have to just go back to what I said earlier, that parents, caregivers out there, and anyone else who's listening to us today should not think of steroids in the same way. So if we're talking about topical corticosteroids, as said earlier, to date, they are the mainstay treatment for eczema. So they are not only effective, but they are also safe, depending. So in other words, in the right use, in the right hands, when they are not used in a prolonged manner, they are both effective and safe. Irresponsible use their irresponsible use may then lead to the side effects that I think justifiably is responsible for the fear that some people have.
Yeah. And I actually had a patient once, and I still get the chills when I think about it, that this particular patient had been using a topical steroid, so a corticosteroid. A topical means a cream or an ointment. So it's basically something that you're applying on your skin. Had been using that as a moisturizer on her face, and obviously developed side effects from that. I do think that is something that the healthcare sector needs to make patients aware of, and now we have this platform to be able to tell people about that. And then these are the cases as well that get so people who use it incorrectly. These are the patients who also develop conditions like steroid withdrawal, steroid and those syndromes that we're reading a lot about online, and it's still something that we're going to be talking about in one of our meetings as well. because this is something that's receiving a lot of attention online. But now we're going to move on to a few Q&A. So let's see. Sorry for looking on my phone, but that's where we will be getting the questions. Okay, we have a wonderful question here. So, doctor, when will I know that it's safe to use my cortisone cream?
When it's safe to use.
Yes. So when is it safe? Because we have so many misinformation that we have online. So when would it be safe?
So firstly, I'm hoping that that corticosteroid is prescribed by an appropriate doctor. I mean, like a doctor, a healthcare practitioner, right? And I really hope that part of the education we're talking about is that the healthcare practitioner who sees the patient for the first time uses the power they have to educate that person appropriately. In other words, don't leave it to the neighbors and the family members and other people to do the education, but let that healthcare practitioner inform the patient. But as long as the healthcare practitioner has prescribed that corticosteroid and have informed the patient what to expect, when to expect improvement, it is safe to use it. I'm not sure what that person, if they already have another disease, but I'm just saying, make sure that it's the right person who's prescribed it. They've taught you how to use it, how long to use it, when to use it. Then do so as soon as you need to.
And then also, I found quite a few patients that just request repeat scripts, and then repeat script. And these are the cases. This is doctors should not be prescribing repeat scripts without following up patients, without seeing patients, isn't it? So it's something that patients need to realize. This is why we follow you up. To make sure that you are getting it for the correct indication and the correct strength in the correct areas, because we have so many of them, isn't it?
So the reason that it is also important for it to be preferably a dermatologist is not only because once the dermatologist has made the diagnosis and has prescribed that particular topical corticosteroid, their duty is also to monitor its efficacy and the side effects, such that if the patient does return for review, and at that point the dermatologist, or let's say even a non-dermatologist, finds that there is now a development of side effects, that it's the right time that they withdraw and offer that patient a different option if needed. But the other benefits of this close monitoring of the use of corticosteroids is also so that if it doesn't work, then at least the diagnosis can be revised. It might not be eczema, it might be fungal infection, and also if it is indeed eczema, then instead of just continuing nonstop, maybe a step-up treatment might be needed. So I just cannot emphasize enough for the person who has such a challenging disease such as eczema to also be treated in the right hands. And I hope fellow healthcare practitioners do take the responsibility of not only just prescribing and let the patient on their own, but monitor it closely and change and step up treatment when needed.
Yes. The other question that we have here is, so mom says that her 6-year-old daughter has eczema around the eyes. And the doctor prescribed the cortisone creams, but she doesn't want to use it because she'd rather treat the cause than actually use the cortisone cream. So what would your approach be to that kind of condition, that kind of situation?
Yeah. So firstly, I do want to commend the mother at that point for, you can say, grabbing the bull by its horn by not using a topical corticosteroids around the eyes. I think, what I hadn't mentioned yet was that topical corticosteroids come in different strengths, mild, moderate, mild, mild, mid-potent, and potent steroids. But none of these potent, it's irrespective of the potency, no steroids should be applied around the eyes. The best way going forward is if a person has got eczema in that area, then the use of the topical calcineurin inhibitor should be the way going forward, should be the one to use. In other words, something that has no corticosteroids within it, but has, where the potential of side effects is lessened. That is where the topical calcineurin inhibitors come in. But in terms of treating the cause, I'm afraid for that mother, I think they are grabbing on straws there, because it's not easy to find the cause for the triggers that patients with eczema suffer from. They will look and may never find it. The best thing is just treat. And then, of course, they have to be observant. If they can clearly associate a particular trigger with the development of eczema, try and avoid or eliminate that particular trigger. But even without looking hard, they just need to treat that eczema.
Yeah. Because one of the articles that came out quite recently, some research that came out recently, showed that that the inflammation that we have in the skin, which is why we prescribe the topical steroid creams and the non-steroid, the similar type of creams that we've been speaking about, that the inflammation actually keeps the barrier dysfunction going. So the inflammation actually keeps the dryness of the skin going. And the dryness then also triggers the inflammation. So it's a vicious cycle, really. And we need to address both aspects in certain cases, not always, but in certain cases, we need to address both. Otherwise, we will never get on top of this barrier dysfunction. The other thing that I've also found is that, especially around the eyes, we found that these children are often sensitized, or they're allergic to house dust mite, for example. Avoiding house dust mite completely is not possible unless you live in a bubble. And living in that bubble is obviously not possible. Despite everything, if that house is from top to bottom, not a speck of dust, of course, you're going to be going to school, going to visit granny. So it's not going to be possible to avoid house dust mite. But treating the skin problem with a moisturizer, so an emollient, and then with a topical steroid or a non-steroid cream, the ones we'll talk about them a bit later. So treating that will actually also improve your sensitization or your allergy to house dust mite, isn't it?
Yeah. Please carry on. No, carry on.
No, go ahead.
I was just gonna say, the one of the gospel I spread is for people to please view use of emollients in the same way as they do use of topical corticosteroids or other specific treatment. Because I normally, how I put it is, what's the point of using expensive agents such as topical corticosteroids or other forms of treatment and still go back to use your normal soaps, the ones that are colorful and scented? It almost nullifies all the good work that the topical corticosteroids are doing. So if you take seriously the use of emollients, corrective emollients, as you do topical corticosteroids, it's a balance that is needed for you to see a difference.
Yes, and now I always like referring to the Barbie bubble bath and the Spider-Man bubble bath. And today, the Barbie movie is coming out, apparently. So, yes, so that is...
I'm worried about seeing a lot more eczema patients coming my way.
Oh, dear. Okay, so we have one last question before we go on to a little video that we're going to look at. Which classes or potencies of topical steroids are safest for children? That's a good question, I think.
It is, yeah. So I feel like the way to view that is not going by classes, but it's going by what eczema they suffer from. In other words, is this patient suffering from mild eczema, moderate, or severe? Because if the patient has got severe eczema and you keep using a low potency steroid, you are not helping. So you use a different strength depending on the eczema that is presenting before you.
Absolutely.
Even in
And that's why you go and see your doctor. And remember, a dermatologist is someone who has studied 6 years to become a medical doctor and then specialize for 4 years in skin problems. So this is, and I think, Carol, I mean, you have to correct me. I think we're about 180 in the country, or maybe 200. I'm not sure. It's the data varies there. But now we're going to move on to, we got some wonderful questions here, but I will read through them while we are looking at a fabulous video that is going to teach us a little bit more about using moisturizers and when to use cortisone creams. Okay, thank you.
Atopic dermatitis, also known as eczema, is a common skin condition that can cause itching, redness, and scaly patches on your child's skin. While there's no cure for eczema, there are ways to manage it and improve your child's skin health and their overall quality of life.
I use moisturizing ointment regularly to manage my child's eczema. They work by making an oily layer on top of the skin, preventing water from getting out of the skin from becoming dry. They should be applied frequently, even 6 or 8 times a day for severe eczema. I always tell Mpilo to use the emollient whenever she feels itchy instead of scratching. After a bath or swimming, I dry the skin gently by patting it and then put the emollient on as soon as possible. I use a thick layer and smooth it on gently from the top of the body towards the bottom.
SBR instantly hydrates the skin and replaces skin-identical lipids. SBR effectively reduces symptoms within 7 days. With daily use, SBR reduces the need for topical steroids for up to 12 months. To avoid contamination, it is always better to use a nozzle or to squeeze from a tube. If this is not available, use a utensil and replace the lid as quickly as possible. Aqueous cream may be used instead of soap, but it should not be used as a moisturizer because it may irritate the skin.
When my child's eczema is bad, I use a corticosteroid cream or ointment directly on the bad patches. They reduce the inflammation and quickly make her skin smoother and less red and swollen. I use a steroid for the fast effect and quick itch relief from day one.
During a flare, the skin is being damaged by the eczema and the steroid ointment will prevent that damage. Once a flare is under control, a lower strength ointment should be used and then slowly reduced until it can be stopped and just the emollient continued. Emollients must be continued at the same time as steroid ointments are used. Use the steroid ointment directly on the skin and cover it with a layer of the emollient.
Mpilo's eczema used to come back very frequently. Then my doctor gave me a different ointment to use once she's better. I put it twice a week where the bad places are to stop the eczema from coming back and to prevent us from having to use more steroids. When Mpilo's skin is really bad, I use wet wraps. I put the ointment on, then cover it with a wet layer of bandages or clothes and then her normal pajamas afterwards. When Mpilo uses wet wraps, she sleeps well and the skin gets better quickly. The next morning her skin is smoother and less dry and itchy, and I find we even use less of steroids.
The Allergy Foundation sells a special range of clothing called kiddie calmwear to make wet wrapping easier and more effective. It's important to identify and avoid triggers that can worsen your child's symptoms. Common triggers include harsh soaps, certain fabrics, fabric softeners, hot showers, and overheating. Work closely with your healthcare provider to develop a treatment plan that's right for your child. Managing your itchiness means you need a plan that includes medicines, avoiding certain things, and using emollients regularly.
Mpilo's action plan tells me how often to use emollients and what steroids and other ointments I should use. I learned to use the emollient regularly to reduce her symptoms, give her healthy skin, and help her live her best life despite eczema.
So I can feel better, sleep better, and enjoy my life with healthy skin.
Help us to help you. Go to the Allergy Foundation website at www.allergyfoundation.co.za and sign up the Allergy Foundation as one of your beneficiaries on your Woolworths My Schools, My Village, My Planet card.
For that was such a lovely video. I think that that was just the mom just explained how to use the moisturizers and the cortisone cream appropriately, really. Carol, what do you say to moms who say they don't want a cortisone script because every time they get the cortisone script, or that it doesn't work? I get that a lot. That moms say that the cortisone doesn't work.
Yeah, so we get that, I'm sure you said you get it a lot, we do too. And then really when a person has come and said, use the cortisone, it hasn't worked, very often I go back and ask, what did you use? How often did you use it? Because very often again, I find that they used it perhaps for a day or two and they stop because either they only then did they realize, oh, this is a steroid, or somebody told them that it's a steroid and then they withdraw. So clearly, so this whole problem of corticophobia, which is what we're addressing today, unfortunately leads to under-treatment of the conditions we're trying to treat, and worse so eczema. Yeah. So if they say it doesn't work, I go deep. Yeah. Exactly how? How long? What strength did you use? For which sides of the body? Until I was certain that all of that was done correctly. As I said earlier, perhaps the right time is to revise the diagnosis. It may not be eczema.
Absolutely.
If it is eczema, then that's when I said, okay, maybe we have to really think about another option, moving a step up from topical corticosteroids.
Absolutely. The one thing that I always ask then as well is, so when you were using it, did it work? And then they often say, yes, it did work, but then when they stop it, it comes back. And that is where the education bit comes in, for people to understand that eczema is a chronic condition and it's part of your genes. It's like having diabetes. It's like having high blood pressure. It's something that we need to maintain. Now, of course, we always hope that kids outgrow it, but they don't always, unfortunately. And in those cases, it's a question of maintaining it. But there are other things that we can also do for maintenance, isn't it? Our moisturizers, of course, we always have to do the good things and stay away from the bad things. I always like saying that. So the good things, or let's start with the bad things. So no Barbie bubble bath, unfortunately. And be careful of too much water exposure, so quickly in and out of the bath. And then the good things, moisturize, moisturize, moisturize. It's not enough for everyone. I get a lot of questions on the support group where people say, I've been moisturizing, and it's just not enough. So in some cases, if that is not enough, then sometimes we go over to maintenance therapy, isn't it, Carol? And what would you, if we look at maintenance therapy, how would you describe that?
So yeah, I think it's your question is so important because it also adds to the whole theme of today, corticophobia. It adds to us answering it in that if a doctor prescribes corticosteroids, then their intention is to use them for a short period of time, because perhaps this is where I can just mention that the expectation of the efficacy of topical corticosteroids is within 2 to 4 weeks. So if corticosteroid has not worked in 2 to 4 weeks, then of course that person needs to go back to the doctor and go over what we've just said. But why I am happy to underline the short duration period that the steroids are usually needed for is because it is true that after a period of time, eczema comes back. It's like, it's the nature of the beast. So they would be treated appropriately with the topical corticosteroids, but the minute the lesions of the lesions of eczema settle a little bit, that's when to introduce a maintainer. And we are fortunate right now that we've got at least 2 non-corticosteroid agents that can be used in between after a person has used effectively topical corticosteroids, and they include topical calcineurin inhibitor. An example, a lot of I'm sure people who are listening to me know about Protopic. They know Elidel. Protopic comes in different strengths as well. And then it just also is fortunate that we've recently had a launch of a different, another topical non-steroidal that has been released in South Africa, which is crisaborole, and some people know it as Stapis. So there are options, but unfortunately, these 2 options, we're talking about calcineurin inhibitors and crisaborole, they do not compare to in terms of the efficacy to corticosteroids. So their best place is as maintainers. Fortunately, and I'm hoping that people people behind these 2 agents also will appreciate the fact that we're not talking about their use in a short period of time, because if they're used as maintainers, it means they're used for a longer period of time compared to corticosteroids. And if that can be balanced, then a person will have only minimal time that they're exposed to corticosteroids compared to if they just use corticosteroids alone. So ideally, you wash correctly, moisturize correctly, use topical corticosteroids when needed, but as soon as lesions settle, you embark on a maintainer, and that you can use for a longer period of time. And in that way, you do not expose your skin to long-term use of topical corticosteroids and therefore avoid the side effects.
Yes. But even sometimes, if that's not enough, so if we have a patient, if we have someone who has severe atopic dermatitis, severe eczema, they've used their moisturizers properly, they've done everything they can from their side, they've used their cortisone creams, they've used the non-cortisone creams, they've done all of that, they've avoided everything they can avoid, while still having a normal life. Yeah. And then sometimes even that is not enough. Yeah. Then what happens then? What would you suggest then? What do you normally do then?
It is true, Suretha, that some children and adults' journeys of atopic dermatitis are more challenging than others. And being at Red Cross and seeing a lot of eczema patients, that's my life. Most patients who come to me are those that have done everything right elsewhere, and they're referred to us only because everything has not worked. I mean, whatever they've used so far has not worked, but they've done everything correctly. So yes, there comes a time when you have to step up therapy. And in terms of stepping up therapy, what options do we have? It's usually, okay, so perhaps I could just list them for starters, and then I'll go back and expand on them. After correct topical agents, being topical corticosteroids, calcineurin inhibitors have been used appropriately and they don't work, the next best step is phototherapy. Some people know phototherapy as lights, and there's different forms, ultraviolet A, ultraviolet B. The problem with that is there's limitation with this option. As much as it is available, but because of the equipment that is expensive, that is needed for this type of therapy, it's only confined to big hospitals such as the public hospitals, Fortescue, Tygerberg, And there are very few dermatologists who keep this machine within them. But not only is that a limitation, but it's also because patients need to go on a regular basis for this particular therapy, Monday, Wednesday, Friday. So it really is a challenge. So yes, it's an option, but it's not practical. But what else do we have? Oral agents. And you want to avoid using oral agents as much as you can until you absolutely have to. Only because of the side effects that they carry with them, especially after their prolonged use. And unfortunately, because they work so well, they do kind of force patients to use them long because they use, and let's just give an example, methotrexate, cyclosporin, and azathioprine. Person uses them, they see the difference. Just because they see the difference, they feel they are stuck, they have to use them. Not that they feel, they actually need to use them because when they withdraw, sometimes eczema comes back. But then the prolonged use means that they may have to be subjected to the side effect that comes with the long use of these agents. So yes, there are other options. I'm talking about in addition to topical corticosteroids, but they come with their own baggage.
Yes. No, absolutely. I mean, I have one of our audience members who is actually one of your patients who said that they are so much better after going on oral medication, so going on these tablets. So definitely, I mean, I hope that the audience sees that as dermatologists, we are not pushing for them to be on topical steroids indefinitely.
Exactly.
We use it in the appropriate time, appropriate place, appropriate strength. That is where we should be using it, and that is that people understand that we are in the therapy, in the treatment program with them together, and that we should be a team really, more than doctor telling you this is it. I'm as a patient telling you, no, I don't want to take it. So we should have that open conversation, and we should address these issues as well. And then, of course, beyond that, in adults or in teenagers, we have a new medication that was approved about 2 months ago, if I remember correctly, and is actually being launched formally now on Saturday. Where the product is called Rinvoq. It's an oral tablet, and it's something that we will be we can use in teenagers as of 12 plus. And then in adults, of course, we have Debunking, which is the biologic that we discussed at the previous meeting, that is also now available in South Africa. And has absolutely fantastic results as well. Unfortunately, not in children just yet, Carol. So, but it is in the process of being registered. Debunking is in the process of being registered, and in the USA, it's already approved from 6 months up. So, so we're waiting for those to become available in South Africa as well. So. Yes, so let's talk about some myths and misconceptions, which is what these meetings have been advertised as. So myths and misconceptions. Corticosteroids thin the skin permanently. What would you say to that, Carol?
So I have to go back to what I said at the beginning, that the fear that the public have in terms of the use of topical corticosteroids is not unfounded. It is true that the thinning of the skin can happen in a patient who have used corticosteroids, topical corticosteroids, as I said earlier, for a prolonged period of time. So the proviso there is that if used irrationally, meaning incorrectly, and one of them is just prolonged, non-stop, no monitoring, it can happen. The thinning of the skin can happen. But another fear I know, in addition to the thinning, they also fear about stunting of growth, which also can happen. But yet again, it's prolongedness, it's the type of steroid that you've used. For example, if you use, as I said, for a prolonged period of time, the mid-potent or high potent steroid, that's possible. But I really want to just quote a study here, because it is an acceptable fear. But there's a study that was conducted, unfortunately, in this case, it was in adults, where these adults had psoriasis in particular, but they used one of the potent steroids, Dovate, and they used it for continuously, but weekly, for a period of 18 months, and in 10 did develop the side effects that associate with that. But as I said, it was not in eczema. For eczema, this was in psoriasis. For eczema, we will expect for the use of topical corticosteroids to be much shorter than that, such as the side effects, such as thinning of the skin and the growth retardation that people fear about, shouldn't happen. So in other words, once it can be identified early enough and it's stopped, the potential of reversal is high. It is if it is left unabated, that yes, skin will thin and other side effects that we fear will then go on.
Yeah. And basically, if your child need to use a topical steroid, especially a strong topical steroid, for prolonged periods, then you need more treatment. You need the treatment needs to be adjusted. So maybe in those cases, one needs to step up treatment and one needs to go onto the oral medications, for example, to get things under control. So the idea is basically still, Carol, I mean, and this is, I feel very strongly about that, and I know you do as well, that we always do the good things, we stay away from the bad things, and that refers to good skincare. And then we use, only when it's needed, we need a topical steroid, so a topical corticosteroid cream once a day, and we need that. We use that until things are under control, and then we decrease the strength, we decrease the frequency of application, and then if we need to, then we use the non-cortisone creams, the ones that you've referred to, Stackwurst, Protopic, or Elidal. So that is really the idea of treating eczema, isn't it? And then sometimes stepping up treatment. So corticosteroids are addictive. What do you say to that?
Also, not unfounded. But what I think, how I view this is that when they are used, because of how effective they will definitely make a difference. So a person will see the difference. So I feel the addiction is more towards they're addicted to seeing their skin clear, and therefore they need to use them. And so there comes a time when, they need stronger and stronger potency for them to maintain that clarity. But I feel like the addiction is more towards seeing themselves clear as opposed to just the steroids themselves being addictive. But I'm very keen to hear your opinion on that one, because I think it's possible for them to be addictive as long as they make a difference.
No, absolutely. The actual definition of addiction is a little bit, it's not really I don't think it's maybe more corticosteroid dependence more than addiction, really, if you think about it, because if you stop it, then you don't really withdraw, So, but I mean, these are technicalities. But although, with a steroid withdrawal, etc., that you can get that, but that's a completely different group of patients and very rare, actually. Although if you look at social media and the internet, it seems to be very common if you look at that, unfortunately. But yes, I found quite a few cases where the patients actually want the cortisone injection more than the cortisone creams, because it's easier to do, isn't it? And the cortisone injection helps for a short time, but then the eczema comes back. So that is those are the type of cases that I find that I need to explain how eczema works, and then the risks of cortisones. So, Carol, can you maybe tell us a little bit about the risks of we've been talking about the side effects of cortisone cream. So what are the side effects? Okay, so we've said that it can thin your skin, and what are the other side effects that we're looking at?
Yeah, so for the topical ones, what we expect is the
Yes.
thinning of the skin, purpura, what is referred to as hypertrichosis, which is overgrowth of the hair in areas that you don't expect too much hair. I think this is where I'll stop for now in terms of the topicals. I'll come back to it. But let's also go back to the systemic ones. I think one of the fears about systemic corticosteroids, the ones that you're referring to, oral or injections, is that they potentiate diabetes. So one of the problems. So if you use them for too long, yes, the person may then develop diabetes or may develop hypertension. But they also will. I'd like you to help me with the long name, but it does reduce the HPA axis, which is why most patients will then develop Cushing's as a result of the systemic agents. But I must say, even the topical ones, especially if they're used for a long period of time, can eventually lead to systemic involvement. So yes, the side effects that I normally observe very much depend on what type of steroid was used. So the ones that tend to just mainly remain on the skin are as a result of the use of topical ones, and then the systemic ones tend to associate with obviously the systemic use of corticosteroids, in particular prednisone, or even if given as an injection, as you said.
Yes, and that is why we as doctors don't recommend using these systemic medications like cortisone, like prednisone, for a long time. But then also we also, of course, like we've been saying now during our meeting, we don't recommend that you use cortisone creams for a long time. But then also, we also don't want you to be scared of it, because we need to get things under control. So we want to put out the fire. And then we want to keep the fire, then we want to keep things nicely under control, but not with the cortisone cream. So actually, doctors don't recommend that we use cortisone creams for a long time, but we use it in the correct time, in the correct place, and under supervision. Under not supervision of your neighbor or your sister who received the cream from whoever, but under supervision of a healthcare practitioner. So here's one that I love. Natural remedies are always better than corticosteroids. So my skin starts to crawl when I hear that, because corticosteroids, everything comes from nature, and even the natural products that you get from some of the other healthcare practitioners, so associated healthcare practitioners, such as homeopathic medications, also contain natural corticosteroids, actually. And people don't know that. And so what would you say to that? Natural remedies are always better than corticosteroids.
Yeah. So the way I view the role for natural remedies is in the same way. I think their place is the same as where emollients are, which is more for mild to moderate. For mild, let's just stop it at that. For mild eczema. So if somebody finds a natural remedy that makes a difference in terms of the mild eczema, I don't mind. But unfortunately, for moderate to severe eczema, I'm unaware of a natural remedy that has the same efficacy as topical corticosteroids or even systemic agents that you've just gone over. So I really cannot recommend any natural remedy, because I don't know of any that really makes a difference.
There are interesting things about that I read in the literature about olive oil, and but these are now, we're talking about moisturizers. We'll keep that for another one. Olive oil and sunflower oil and coconut oil. So these are things that we can speak about in the future. Let's look at just a last few questions, Carol. Here is a nice one about, I've been using bepanthen on eczema around my eyes, and it has worked for me for many years. How does that product compare with corticosteroids? I love that question, actually. So what would you say to that?
I like the ingredients of bepanthen, I must say. It's a combination of ingredients go into that particular formulation. But the way I see this is that it's servicing that person as a barrier. It is helpful as a barrier, and I'm for it.
Yes.
It's just that I'm sorry that if it does, I think they probably don't have as bad an eczema as I said, the type of patients I see here at Red Cross, which is severe, such that I do not see bepanthen on its own being helpful if it's severe eczema. But yes, as an adjunct, I don't see why not.
And once again, emphasizing my little rhyme: stay away from the good stuff, stay away from the bad stuff, do the good stuff. And then sometimes when that is not enough, because bepanthen is now one of the good stuff, right? So it's a moisturizer. Yes. So then we add a cortisone cream, or this is now around the eyes, so a non-cortisone cream. So we add that when we need it.
Yeah.
And then if we don't need it anymore, we take it away. Yes. So that is the ideal of using these products. So, Carol, we have just a few more minutes left, and I'd like you to leave us with your pearls of wisdom. So what would you like our audience to remember? Maybe the 3 most important things that you would like our audience to remember.
Firstly, I cannot emphasize enough that, contrary to popular belief, the risk of adverse events with corticosteroids outweigh the benefits. And I think we've expanded on these to say, in the right hands, topical corticosteroids are safe and effective. That's, for me, is the point 1. And, or maybe before I carry on, I do want to also just remind people that, I mean, when you compare it with the detriment effects that uncontrolled eczema has, I mean, we all know about the itch and the poor sleep and social isolation. So I really think the benefits outweigh the risks. That's point number 1. Secondly, I just wish to, I hope there are healthcare practitioners out there who are listening that can assist us with spreading the correct message across. But I also would love to equip even us dermatologists, hopefully there's some listening, to say when a patient is prescribed topical corticosteroids, it's best we are proactive. You don't wait for the patient to come back to you when they've got complaints. Quickly address the fact that they may fear skin thinning, they may fear growth suppression. Immediately address that as you prescribe, so that they don't go back to another doctor and say, I wish that my first doctor told me that I shouldn't, this is how this should be used, I would have used it correctly. Mm-hmm. That's the one thing. And I think if I were to just underline for the audience that I truly do understand why there is that fear of topical corticosteroids, the side effects of them, it is not unfounded. But remember, in the right hands, they are effective and safe. That's all.
Yes. No, absolutely. If used correctly, then cortisone is 100% safe. And actually, as you said, very important to make sure that we get this inflammation of eczema under control, because it has such a profound effect on your life. Thank you so much, Carol, for joining us again today. If the audience has any more questions, you're welcome to post it. It's still of course, if you have any questions, because I know that not everyone could attend this time of the day, but hopefully they'll view it later, and then post your questions if you have any, and then if I can't help you with the questions, then I'll ask Prof. Clela to help as well. And then please make sure that you see a dermatologist or an allergist with a particular interest in atopic dermatitis, eczema, to get your eczema under control and to try and keep it under control as well. And it was so lovely seeing every one of you today again. Sorry, my tongue is tying now. And I hope you have an absolutely lovely day further. And please join us for our next session, which is going to be on World Atopic Dermatitis Day on the 14th of September. And we're looking forward to sharing the new developments in atopic dermatitis in that particular session. So it was absolutely lovely being with you. And let's spread the word that steroids are not bad for you if they are used correctly. Thank you.
Thank
Bye.
you.